Welcome everyone to this explainer. Today, we're doing some high-yield clinical rounds on a really fascinating dermatologic and surgical pathology, Calcinosis cutis. Let's just dive right in, because getting a solid grip on this specific condition beautifully bridges that gap between your foundational pathophysiology and the actual practical surgical management you'll be doing on the wards. We've synthesized the absolute core tenets of this pathology, so you can easily recognize it and, more importantly, treat it.
So here's our quick roadmap for today. Section 1, defining the pathology. Section 2, the mechanism of calcification. 3, clinical presentation. 4, key differentials. And finally, Section 5, surgical management.
All right, Section 1, defining the pathology. Okay, so the absolute crucial point right out of the gate is understanding that calcinosis cutis falls squarely under the umbrella of dystrophic calcification. Now, what does dystrophic actually mean in a real-world clinical context? Well, it means this calcification is happening in or directly under the skin in an environment where the patient's systemic calcium and phosphate blood levels are actually completely normal, right? The issue isn't a systemic mineral imbalance like you'd see in metastatic calcification. Instead, it's a very localized, targeted tissue problem. Calcium is basically depositing directly into damaged, dying, or degenerated local tissue, completely leaving the healthy surrounding tissue untouched.
And clinically, this shows up as a highly circumscribed lesion. When you're in there doing a physical exam and you run your fingers over the patient's skin, you aren't feeling this diffuse, poorly defined induration or swelling. Not at all. You're feeling a distinct, well-bordered, circumscribed nodule or plaque. It's this highly localized, palpable mass sitting right there in the dermal or subcutaneous layers, and it feels completely structurally independent from the nice, pliable, healthy skin around it.
Moving right along to Section 2, mechanism of calcification. Let's walk through the exact step-by-step biological cascade here. It all kicks off with Step 1, which is friction. We're talking chronic, repetitive, mechanical stress on the epidermal and dermal layers. And this constant rubbing leads directly to Step 2, tissue degeneration. The skin and those immediate deeper connective structures literally begin to physically break down and necrose under all that constant physical stress. Now, as those collagen bundles and local cells degenerate, the whole microenvironment shifts, which brings us to Step 3, increased local alkalinity. The pH of this specific, damaged tissue pocket spikes. It becomes abnormally alkaline. And honestly, that chemical shift is the final trigger. Because in a highly alkaline environment, calcium salts become incredibly insoluble, which forces Step 4, calcium precipitation. The calcium literally drops right out of solution and crystallizes right there within that degenerated tissue bed.
So what does this entire biochemical cascade actually look like to the naked eye when you're scrubbing in? Well, the gross pathology is pretty striking. The precipitation creates this remarkably solid, hard swelling in the skin. When you take a patient to the OR and make that initial scalpel incision, you are going to hit a gritty, almost rock-like resistance. The cut section of the lesion reveals this hard, yellowish material. Seriously, if you've ever seen high-quality clinical photographs of an X-size specimen of Calcinosis cutis, that chalky, dense, yellowish calcified core is absolutely unmistakable. It's exactly what you'd expect from precipitated calcium salts that are just embedded heavily into necrotic dermal tissue.
All right, Section 3, clinical presentation. Let's take a look at the classic patient demographics. Statistically speaking, looking at the clinical literature, this is a lot more commonly seen in female patients. Another huge feature to note during your H&P is that it usually presents bilaterally, so on both sides of the body at the exact same time. But the most revealing diagnostic detail here, and I really want you to connect this back to our pathophysiology chat a minute ago, is the anatomical location. The most common site? The waist. Just think about the mechanics for a second. What do we say was Step 1 of that calcification cascade? Friction, right? The waistline is basically ground zero for chronic repetitive friction from belts, tight trousers, rigid undergarments. This continuous bilateral mechanical friction perfectly explains exactly why these hard, yellowish swellings predominantly pop up in this exact anatomical distribution.
Section 4, key differential diagnoses.
Time to put on your diagnostic detective hat, because calcinosis cutis has a couple of tricky clinical mimics that you're definitely going to encounter on the wards. Specifically, a calcified lipoma and a neurofibroma. Let's break those down really quickly. So a lipoma is a super common benign fatty tumor, right? But occasionally, if it outgrows its blood supply or takes some localized trauma, it can undergo fat necrosis and then calcification, which makes it feel really hard. On the flip side, a neurofibroma is a benign nerve sheath tumor that can also present as a firm, circumscribed dermal or subcutaneous nodule. Now, accurately differentiating between these three is absolutely critical because your surgical margins and your whole approach are going to change depending on what it is. Sure, a simple radiograph or ultrasound can easily confirm the dense calcium in calcinosis cutis or a calcified lipoma. But honestly, it's that classic bilateral waistline presentation combined with a detailed patient history of localized friction that should heavily tip your clinical suspicion right towards calcinosis cutis.
And finally, Section 5, Surgical Management.
Here's the deal. Medical and topical management generally completely ineffective for these rock-hard, chalky deposits. So we have to turn to surgical intervention. The treatment protocol is pretty straightforward in theory, but it demands precise technical execution. First up, complete surgical excision of the lesion is a must. You have got to get all of that hard, yellowish material out, along with the immediately surrounding degenerated tissue if you want to prevent recurrence. Second is the closure of that resulting tissue defect. And this is exactly where it gets a little complex for the operating surgeon. Because you're excising a rigid mass of skin and subcutaneous tissue, simple primary closure, where you just pull the wound edges together in a straight line, just isn't always possible. The skin might be way too tight, especially when you're dealing with a tension of a dynamic area like the waist. Because of that, closure often requires the skillful use of local tissue flaps. By undermining and mobilizing the adjacent healthy skin, the surgeon can get creative and close the defect without putting the healing wound under excessive, damaging tension.
This whole real-world challenge of surgical planning actually leaves us with a final, kind of provocative thought to ponder for your next surgical rotation or study session. Think about this. If your local flaps fail due to ischemia or tension, or if your initial excision of that degenerated tissue is inadequate, what are the cascading risks for wound healing over a high-friction site like the waistline? I mean, a wound breakdown here doesn't just mean a bad scar, it means exposing the deep, healing tissue to the exact same chronic friction that sparked the alkaline shift and the calcification in the first place. It's just a fantastic reminder that in medicine and surgery, deeply understanding the initial pathology is the ultimate key to executing a really lasting, successful repair. Thanks so much for joining me on this explainer. Keep those clinical skills sharp, and I'll catch you next time.